I think all the changes that were made were on the other one. Okay. Let me pull up a different slide set. I think that will have. So let me show you this particular case. So we'll switch back and forth between this. So having a pre-ablation CT scan would be helpful to appropriately size the catheter for you. Measuring the ostial diameters of all the veins can help you to appropriately size your balloon. If somebody has really small pulmonary veins, then I think going with a 23 makes sense. If somebody has larger veins, then picking up a 28 millimeter catheter makes sense in those patients. So check for PV potentials. This is an example of the left superior pulmonary vein. Before ablation, there is CS spacing going on, and then you clearly see the presence of the double potentials on the achieved catheter. And then this is the LIPV. Before the ablation, you come across all the potentials. So this is the case where you're trying to get the LSPV from the tip of the ablation of the cryoballoon catheter. You can actually inject contrast into it and then be able to visualize if you're able to accomplish good occlusion of the vein or not. I mean, this is a pretty decent occlusion here. I mean, once in a while you see a little bit of a leak from the superior aspects of that left superior pulmonary vein, but again, this is as good as it gets. Early on, it is always very unnerving to take this humongous balloon and then try to push it across against the atrial tissue, the process of getting that occlusion. But you have to really apply some decent amount of force to really get that occlusion. Since this is it's a pretty soft, smooth balloon, the risk of perforation is pretty low on this. I think getting that appropriate amount of force and the contact with the atrial tissue makes all the difference in terms of your ability to successfully deliver a lesion and minimize the number of secondary applications that you would need for each of these veins. So this is the left superior pulmonary vein post-ablation. As you see it here, the double potential that was seen earlier is actually gone. And this is the concept of differential pacing to basically confirm the presence of the far field potential from the left atrial appendage that you've been seeing in the left superior pulmonary vein. Again, this is the LIPV, picture of which we have shown. Post-ablation, you don't really see much of any atrial signal there. There is some dissociated firing here with a little bit of ectopic activity inside the left inferior pulmonary vein post-ablation. And this is a good example of LIPV post-ablation where you have pacing going on from the coronary sinus, demonstrating the entrance block, and then there is exit block with none of these ectopic beats that are generated inside the left inferior pulmonary vein are able to make it out into the left atrium, a good confirmation of an isolated left inferior pulmonary vein. So this is the right inferior pulmonary vein before isolation, and you definitely see double potential in there. And this is where we actually had the RIPV occlusion. What you see there is a slow, intermittent stimulation of the diaphragmatic nerve with a catheter that's placed at the SVC. So this is one area that is very important when you're ablating the right-sided veins, more so with the right superior pulmonary vein than the right inferior. You would want to pace the diaphragm, the phrenic nerve, to be able to appreciate the excursion of the diaphragm in such a way. I mean, you don't really have to pace it very fast. It can be pretty slow. And when you come on the cryo application, and the moment you see the diaphragmatic excursion slowing down, you really want to thaw out and change the position of your ablation catheter, and then you should be able to reapply and be able to isolate the vein. So This is the right superior pulmonary vein. Again, there is a contrast going through. You don't really see much of any leak around it. Again, a sign of a good occlusion. And this was a case where a diaphragmatic paralysis actually happened, and where you're able to see the paradoxical motion of the diaphragm, with how it actually moves across against the rest of the chest cavity there. So that can potentially happen in these cases if proper attention is not paid to, and then if you don't make an attempt to really stimulate the phrenic nerve on the right side when you're ablating the right superior pulmonary vein. This is the RIPV post. You pretty much see not much of any electrical activity there. This is RSPV post with both the entrance and exit blocks demonstrated. So most of these cases, as everybody has started adapting using adenosine as one of the confirmatory tests to demonstrate the dormant conduction, we also do that on a pretty routine basis. I would like to show you some additional stuff here, since my jump drive arrived. Okay. I wanted to share a few of the independent European studies that were done. So this is a series of 3 different studies that were done showing the role of Arctic front balloon in relatively smaller number of patients. They were able to get anywhere between 72 to 77%, depending on the patient substrates they looked at. That's a pretty decent number, and the number of complications were pretty similar to what we have seen in the STOP-AF trial. The biggest problem that I've noticed is the higher incidence of phrenic nerve paralysis. They've not really seen much of any pulmonary vein stenosis. That's actually one of the biggest advantages that are touted by this particular energy form. And the risk of perforations, I think that is still there. We have a pretty big sheath and I mean a big hardware that you have to manipulate. But again, if done properly and taking all the necessary precautions, as Dr. Balbir Singh talks to you about how whenever you advance a catheter through a transeptal sheath, you always have to proceed it with a wire or a soft-tipped catheter in order to be able to minimize the trauma from the tip of the transeptal sheath. A recent meta-analysis actually dissects the data pretty nicely. There was really not much of a difference between the cryoballoon ablation as well as the RF ablation techniques. The 12-month freedom was about 73%, which is still a pretty decent number. The incidence of phrenic nerve paralysis was about 6.38%, and pulmonary vein stenosis in this particular meta-analysis was seen in about 1%, close to 1%, and a pretty small risk of stroke and so forth. What I was actually impressed at is the esophageal ulcerations and the number of pericardial effusions and tamponades that they have come across. The STOP-AF trial that was presented a couple of years ago, drug versus cryoablation, the baseline characteristics are not really much different between these two people. The acute outcomes and the effectiveness results are definitely in favor of the cryoballoon. So a good pulmonary vein isolation technique, either you use cryo or RF, again compared against a drug, is definitely superior. So their 12 months outcomes were about 70% success rate compared to a pretty paltry 7% for the drug. Operator experience and learning curve plays a big role here. So obviously the treatment success rate is very contingent to the number of cases you do. Like anything else, the confidence in the technology and the ability to really push the balloon across well and position the balloon properly to get a good occlusion before you freeze comes in by doing a few cases. And so the single procedure success rate was about 60%, and about 19% of these people ended up having redo procedures. That ends up with a cumulative success rate of about 70% at the end of 12 months for these. There were 5 people who had experienced complications, including 2 patients that had pulmonary vein stenosis and 1 cardiac tamponade, worsening atrial flutter, and so forth. There were no atrial fistula in this particular series, 1 stroke. There were a total of 7 patients who had pulmonary vein stenosis, and about 29 of them ended up, which included the drug cryo crossovers, had phrenic nerve palsies. And these are the details of the complications, which I think are not relevant to this talk at this point in time. So with that, I will conclude and take any questions if there are any. And I heard that the Indian government just gave the permission to allow this catheter to be commercially available here. Yes, sir. Okay. In the early on, when we did these cases, the first few cases where we reapplied and I was not able to get a good occlusion, then obviously I basically took out an RF catheter and touched up a few things. But as the learning curve gets better, your confidence in the catheter gets better, and then if you're unable to get a good occlusion in one angle, you can actually prop the catheter up. A pull down technique or a pull up technique will enable you to get a good occlusion. So the same thing applies even to the laser balloon catheters or any other balloon technology. So touch up has become less and less of an issue nowadays than what it used to be at the very beginning. So you can, whenever you don't get a good occlusion in a particular segment, so what you can do is make sure you move your balloon well in that particular sector and then see if you can get a decent contact, and then reapply the cryo lesion. You should be able to get it isolated.
Regarding this phrenic nerve, it should be reversible if we recognize it early enough. So is there a way to monitor it, like fluoroscopy or something?
I mean, we bring them in for a fluoroscopy at 1 month. And
no, at the time of applying cryo. If we recognize it early enough, it should be reversible. Or you think it's a late complication?
Yes.
Yeah,
I mean, if you understand that you're getting phrenic nerve palsy, the phrenic nerve stunning, before it becomes paralyzed, by coming off and thawing it, I mean, most of the cases we have seen it get better by the end of the case.
There is some recent work being done in Europe trying to monitor diaphragmatic myopotentials during ongoing cryo application. And there is encouraging data to suggest that a reduction in the amplitude of diaphragmatic myopotentials precedes any detectable reduction in the movement, and therefore you can actually detect it earlier before there is actually any change in the contractility.
So is that a surface patch that they put on?
Yes. Yeah. So this is very encouraging, and I think iterative versions of this, perhaps recording directly from subdiaphragmatic regions, may also provide a higher discrimination, higher sensitivity in the reversible phase of cryo injury to the phrenic nerve.
Because you have a much bigger area of target, right? With RF ablation, it's only a single point lesion, where here you have a 28 millimeter balloon catheter that's creating even a much bigger balloon, a crystal that has a much bigger area of capture. So that explains the increased frequency of phrenic nerve involvement in this case. What about the durability of cryolation? Do we have any data on this? Well, at least in the series in the Stop AF, of those redos that have the 19% redos they did, they were happy to say that there was only a segmental reconnections in a few areas that they were able to get to. So we don't have as much data as you have on RF ablations, but again, it's pretty similar to RF in a sense that, but there is no back-to-back studies to really give the hardcore information.
There's some data from Hamburg where they looked at recurrence systematic fashion of cryoablation. They found that the highest incidence was in the inferior aspect, the inferior vein, typically the right inferior pulmonary vein, and that they say that the use of contact pressure is not ideal.
That's good.
The pull-down technique is developed as a response to that localization. So it appears that the degree of contact that you get in the balloon is determinant for a long-term delivery. And the areas where you get recurrences are areas where you have poor contact or flexible areas.
And the inferior veins typically happen to be the most difficult ones to get a good occlusion with the balloon. So oftentimes you may have to do a typical loop around to get the balloon shoved into that.
Thank you, Doctor. I think we can ask more questions during the lunch hour. We are really running behind time. Thank you so much. And this is really a very good example how exciting new technology can